Greetings and welcome. I'm Mimi Kaiser, and I'm with Emory University and the Interfaith Health Program here, part of the academic consortium, supporting a series of webinars. This is the third in a series of four, generating evidence on the distinctives of faith-based organizations in the HIV response. I will be your facilitator today, and we will be monitoring sort of behind the scenes your technical support for this. If you'll notice, for your participation, maximizing the use of engagement during this live time can be found by the use of questions. The question function in a dialog box on the right. If you click on that, it allows you to designate who you're sending it to and to send us a question. We'll be able to respond to those either in writing or by speaking when we open the floor for discussions and questions. Otherwise, you'll be muted during the time we're together. There is also a raise hand function. If you'll note that in your attendee participation list, if you should need to get our attention. There are many ways to communicate with us during the webinar. So communication would be related to logistics, and then for questions that you want to engage the presenters for content. We'll be recording the webinar today, and it'll be available as the others for playback in the future, and we hope that you would take the time to share this with your colleagues. I will introduce my colleague, John Blevins, Professor John Blevins here at Emory, who will begin the webinar by giving a background briefly on himself, and then an introduction to the webinar series and the support and sponsorship of the UNAIDS PEPFAR initiative that's bringing this to you. Thank you and enjoy.
Thank you, Mimi. I'm John Blevins. I am also on faculty at the Rollins School of Public Health at Emory University and direct the Interfaith Health Program. This webinar series is one activity among many that is part of a joint initiative between UNAIDS, the Joint United Nations Program on HIV and AIDS, and PEPFAR, the U.S. President's Emergency Plan for AIDS Relief. It's a multi-year joint initiative to strengthen partnerships and collaboration with faith-based organizations at local, national, and global levels in maintaining a multi-sectoral response to address the challenges of HIV and to maintain progress made against the disease over time and to continue to build on those the results of that progress. There are a number of activities and implementing partners from various religious traditions who are part of this initiative, and one of those sets of activities are being carried out by a consortium of universities. That's the academic consortium for the joint initiative. Our university partners include Emory, the University of Cape Town in Cape Town, South Africa, St. Paul's University in Limuru, Kenya, the University of Jos in Nigeria, and the Muhimbili University of Health and Allied Sciences in Dar es Salaam, Tanzania. We are working together as a consortium to carry out a number of applied research projects and capacity building initiatives for various implementing partners as part of this work, and this webinar series is one of those activities. Various program implementing partners asked the academic consortium to develop a webinar series to help them to understand the interface between their own work and the priorities and expectations of global and national funders and policymakers in regard to ongoing efforts to address HIV. And the webinar series that you're part of this morning is one of those initiatives. This is the third in a series of four. The earlier ones are also available online and can be viewed at your convenience. And the fourth one will be the first Tuesday in March and will complement the one today, looking at the distinctive contributions of faith-based organizations and local religious communities at a community level. The one today looks at the distinctive contributions of faith-based health providers providing clinical care and medical services to communities around the world. So with that background, I'll turn it over to my colleague from the University of Cape Town, Dr. Jill Olivier, who will lead us forward as we begin the webinar. Jill, to you.
Thank you, John. So John's introduced himself. Let me just introduce the other people that will be doing some of the speaking on this webinar. So I'm going to do a little bit of an introduction and overview onto this main topic. As John mentioned, my name is Jill Olivier. I'm at the University of Cape Town in the Health Policy and Systems Division, and I'm also the director of the International Religious Health Assets Program. And then we're really honored to have Mr. Peter Yeboah, who is the Executive Director of the Christian Health Association of Ghana, as well as of the African Christian Health Association's platform, to give a response from a practitioner's perspective after I've done some input. So without taking any further time, let me just jump into this topic, which on the surface can seem like a relatively dry topic. You know, why would we want to even be talking about, you know, the distinctives or the numbers or the statistics about these things? But actually, it's an issue that really sits at the heart of a number of really important and high-level advocacy and kind of evidence-based decision-making processes. And so, what we're going to do first is just give some level of overview as to this topic and why it's interesting and important, and then speak more to based on our experience and our work, where we think this particular issue should be going in further. Just to cover again a little bit of what John mentioned, this is the third in a series of 4 webinars. What we have decided to do is to split the last 2 webinars. They're both going to be on the same topic, which is these distinctive characteristics and the evidence and the research on these. But in this webinar, we're going to be focusing on a particular type of FBO, or faith-based organization. We're going to be focusing quite specifically on faith-based health providers. So those are institutions and networks of institutions whose primary identity is around the provision of health services, as opposed to the variety of other types of FBOs, which we're going to be addressing in more detail in the 4th webinar. So moving on, I'm just seeing if I have control here. No, can we go on to the next slide? And the next one, thanks. So, no, sorry, if you can just go back, please, to the one with the red. So there's been a long history of statements about the distinctive characteristics of faith-based health providers. These are just a small sample of quotes that I pulled out, and they're the ones that could just fit on the page. You could keep going with thousands of pages of claims about the percentage of so, for example, this one from James Wolfenson, who was at the time the head of the World Bank in 2002, is a classic one. About half the work in education and health in sub-Saharan Africa is done by the church. There's classic claims around 30 to 70% of health services are provided by faith-based organizations. And these types of claims have become I suppose what we call a discourse unto themselves. They have become so commonly used that they have become a kind of commonly accepted fact that you don't really have to provide references for anymore because you know it's seen as something that's commonly accepted. And in around the era of around early, so the turn of the century, around 2000, there was a particular need for these types of claims. It was in the era where people were noticing that faith-based organizations and faith-based health providers weren't visible on global maps. It's the era where people were saying, oh goodness, they're not at the policy table and they're not being adequately recognized for the work they're doing. And that is the sort of the place that these types of statements started. Can you just go to the next slide, please? So what you then get is you get a series of estimates, common statements about the percentage of health or health services or hospital beds provided by faith-based organizations. They usually are in the opening sentence of some kind of report, or they're normally placed in a very prominent place. They're normally at the beginning of a speech or a statement. You can find these kinds of estimates in academic materials, you can find them in funding reports, you can find them in advocacy materials, and they normally are quite prominently placed. And they normally actually have a kind of a sister statement, which is something then about a characteristic, a comparative characteristic. So we'd normally say, half of health services are provided by faith-based organizations, and they also have a stronger reach to the poor, or they have high levels of community trust or user satisfaction. Again, these claims are very often not referenced, or not, there's no evidence provided for them, but they again are kind of these common kinds of statements. Now, this might seem like a vague kind of delving into wordplay here, but it really isn't. These estimates and these numbers are sitting at the heart of some very serious negotiation that's been going on, both at an international level and at a national level. So, for example, at an international level, the policy engagement around the need to take a notice of faith-based organizations, the need for fair and equitable funding to go towards international faith-based organizations, the need to recognize the work that is done. All of that is very often based on the so-called evidence provided by these estimates. At a national level, you'll very often find the faith-based health providers using these estimates as a core negotiating or a kind of piece of advocacy underpinning evidence that they use in their negotiations with governments. So, for example, you need to take notice of the proportion of organizations of healthcare provided by faith-based organizations, and therefore the government needs to treat that sector fairly, or the government needs to provide better financial or other support to that sector. And it's normally those estimates. And in many countries in Africa, what has happened is these very rough estimates have been asking for an absolutely similar percentage of funding. So, for example, in some countries, they might say, we provide 20% of health services, therefore we should get 20% of the national health budget. It's that level of advocacy and argumentation going on. So it's generally is these international and national faith-based health networks, such as the Christian health associations, who are driving this discourse. But it's also perpetuated by researchers, especially in research reports and briefs. And I just must point out that most of the work on this has really argued that you really need to be suspicious of these estimates, especially when they are totally unreferenced and you don't know what the basis of that estimation is. Because very often that reading at the bottom, we wrote a whole paper sort of tracking how these estimates had kind of been picked up and adapted over decades, and actually the originating resource material was just not there in the first place. But because people had referenced each other and referenced and re-referenced, it had become a kind of a fact unto itself. Okay, next slide. So what you then have is a number of different estimates. This one is just a particular estimate that was provided in a paper that was in a Lancet edition, and that, as you can see, there's a set of African countries on this table. Again, these are just the countries in which we could fit onto the slide, and as you can see, there's the self-declared, and now that acronym is National Faith-Based Health Network Share, usually based on an estimation of how many hospital beds they have. So not covering things like primary health care or outpatient care or health promotion or any of those other kinds of activities. So normally based on how many beds are owned. And also that estimation that, so for example, for Benin, that 40% estimate is the estimation of beds, and it's comparing the faith-based health providers against the public sector. So not including the private for-profit or other private non-for-profit sector. So that is not it's not a 40% of all national, it's a 40% against the public sector. Now, again, you might be thinking I'm kind of picking at things that are just too sort of, you know, and people just want a general estimate, but it starts becoming a problem if you don't understand what these figures actually represent. So the next slide. So some of the problems that sit underneath these estimates is that actually what you're very often doing is you're comparing apples, oranges, and elephants. And again, this comes from some earlier work that's been done. The database the evidence base is extremely fragmented. It's slowly getting better. I mean, I must say that there has been in the last 5 to 10 years, there's been some really good work on this. But very often it's not clear what you're actually comparing. So some people are comparing the numbers of beds, some are comparing the numbers of facilities, patients, drug dispensing, and then these kinds of estimates just get merged together into some kind of joint estimate. The other point to make is this is a highly politicized evidence that is extremely important to different advocacy messages and advocacy processes. So, for example, if you as a researcher come along and say, oh no, I'm sorry, but the estimate in Malawi is not what you're busy using in your negotiation with government, but actually it's 10% lower because I've now counted it based on outpatient utilization. The evidence might be supportive of what you're doing in a more precise way, but you're actually undermining a massive advocacy process, which then can be turned around and flipped around and utilized in other ways. So it's a case of saying, yes, we need more evidence, it needs to be more robust, but there also needs to be a huge amount of caution in how these estimates are utilized, and then to ensure that you're not just feeding into a kind of a counter advocacy argument. And so there's a great deal of care that needs to be taken with how these types of estimates get utilized and how they get debunked as well. So just to repeat, I did mention this earlier, very often just things to look out for is that these estimates tend to be about public versus private, not public, and they tend to be public versus private not-for-profit. Generally, the rest of the private not-for-profit sector is generally not counted and is invisible, and the private for-profit sector is generally the big blank evidence gap in most countries in lower middle income settings, where the size and market share and health service provision of the private for-profit sector is simply just not known. It's also quite problematic because it kind of puts all faith-based entities into the same boat. It assumes that all faith-based health providers are the same across all LMIC settings, and this is simply just not the case. Even in one country, you'll have a variety of different types of faith-based health providers. So, for example, you might have some facilities that are co-owned. You might have some facilities, very commonly in Africa, for example, where a facility is acting as a public hospital. It is acting as a district hospital, for example, but is still owned by the church. So there's a variety of much more complex arrangements and contractual agreements that make this rather simplistic kind of counting of beds rather problematic. Also, the evidence that is available is massively focused on a particular set of African countries, specifically countries that have Christian health associations, so these networks of faith-based health providers, because part of that that CHA role has been to try and provide these estimates and utilize it in advocacy. And so what we tend to do is we tend to utilize those estimates for global evidence. And really those estimates are for countries where there are much more substantial sectors of faith-based health providers. And so when you take a set of 24 to 27 countries which have very substantial faith-based health providers, and then you use that estimate for the globe, where in some countries there are very few to none faith-based health providers, it then becomes extremely problematic. Okay, next slide. So why are we even discussing this? I mean, why is this a problem? So the one problem is that the overestimation of market share, the overestimation of contribution of faith-based health providers tends to get really easily challenged in those advocacy settings. It's very easy for governments or for international funders to say, hang on, the evidence underneath these figures is just wrong. It doesn't feel right. I can pull out a different estimate and counter your narrative. And so the poor evidence base then makes it rather easy to push up against a particular advocacy agenda and process. And other things tend to get underestimated. So for example, everyone has been so focused on counting the numbers of hospital beds that in fact there has been very little rich work on, for example, reach to the poor, or the complexity of how faith-based health providers fit within a health system, a functioning national health system. So these type of estimates really provide, they rarely provide evidence that can be used properly in negotiation and advocacy, and it really provides evidence that can speak to the urgent public health or global health agendas of the day. And I want to spend just a little bit of time just going through some of these examples that I've put out here. So for example, the issue of access is a widely studied and widely examined issue, commonly looked at around the axis of affordability, availability, and acceptability. There are maybe a handful of studies that speak to the comparative access of faith-based health providers in relation to public sector or other types of private sector. Issues of equity. Issues such as universal health coverage, which, you know, as one of the key indicators of the Millennium Development Goals, is becoming a massively important global topic. But again, very little actual evidence that can be utilized to show the contribution of faith-based health providers to universal health coverage. The real and current rural-urban health provision split against the public sector is something that is generally just not known at the moment. Again, what the actual reach to the poor, I can't stress enough how important it would be to have some type of evidence that showed that faith-based organizations do have a robust reach to the poor, even at a higher cost. You know, those kinds of things, because the orientation of systems toward health systems towards the poor is a global goal, for example. Cost to households, the issues of user fees, the next line, comparative quality of care, efficiency, utilization, user preference or satisfaction, retention to care, issues such as drug availability and supply chain, sustainability of services, what impact health promotion activities have had, the resilience of faith-based health providers. So for example, there has been some anecdote about how faith-based health providers and their health workers remained in place and functioning during the Ebola crisis in West Africa. But again, it's anecdote, and it hasn't actually been shown to any particular extent that would be convincing at an advocacy level or at a policy level. Health systems responsiveness is a massively important topic that is being discussed at a global level. And for example, that is, how does a health system respond to its citizens' needs? What is the level of dignity provided to the patients? And issues such as special consideration for marginalized groups, that is key information that everybody is seeking. There are evidential holes in relation to fragile and conflict-affected countries. We know that in fragile states, faith-based health providers play a particularly important role. So in the DRC, for example, we know that the faith-based health providers have been holding the national health system in place for decades. But again, there is not a robust study that can be utilized and evidence of that. And in particular, the role of faith-based health providers in non-African settings, because Africa has been the focus. Again, issues such as contribution to high quality human resources for health training, governance, community accountability, all of those types of things. Okay, next slide. So all of those things are the areas where they are extremely hot topics. They are issues in which global focus is currently on, and in which any form of evidence would enable faith-based health providers, their partners, their funders, and others to legitimate a focus on them, to legitimate further support to them, to legitimate bringing them to the policy table. That is the type of evidence that actually would enable a further conversation, whereas the more generic sort of discourse about the comparative advantages of faith-based organizations is in fact, I would argue, now disabling the advocacy approach. There is a slow emergence of some new evidence, but I just have to stress that you have to go looking for it quite aggressively. So these examples are just some random samples that I've been collecting over the years, where you might have a national study, and in the study there is some data on the comparative sort of public health differences of the mission or the faith-based health provider facilities. But again, it's a case of, you know, that this type of evidence hasn't been translated out into advocacy work. Next slide. And beyond research, I just wanted to stress that the faith-based health providers and their regional networks themselves have been focusing on this, and I'm sure Peter is going to speak to this in a minute, but I just thought I'd put the slide up here. So for example, on the right-hand side, this is the Christian Health Association of Ghana's, it's in their foyer, I think, Peter, and as you can see, I mean, option number 8, option for the poor and the marginalized. But the real question, and I believe that this is a core value that all of the Christian health associations and their members are deeply committed to. But the real challenge is that there's very little evidence for that preferential option for the poor. Even just a tiny bit of evidence would be really useful. On the left-hand side is just I just wanted to stress that a few of the CHAs have started trying to seek information from their members. So, for example, asking questions about, you know, really basic information about what types of pro-poor measures and practices do you have in place. But I must stress that this is a very basic type of question, and it's not the type of in-depth sort of equity study that would be, you know, that would be accepted by a higher level funding institution, for example. But there is also a wealth of information, and this picture in the middle is just a standard kind of patient record room from a faith-based organization in Zambia that I took, and just to remember that there is evidence out there, the evidence is available. It just requires focus and synthesis and pulling together. Okay, so next slide. So where do we go from this? I mean, I think that in a sense there is a general call, and there has been for a number of years, but there's been a call for more evidence generally about faith-based health providers, and I think we're moving off that, and we're saying, well, what we really need is much more precise evidence. And that for the faith-based health providers themselves and the Christian health associations and the national networks and other international institutions, there really is a need to be more precise in how we utilize evidence. So for example, the days of making general broad statements about the market share and how faith-based organizations are more trusted has actually become more of a problem than anything else. And there's a real need to learn and to build capacity for advocacy that is evidence-based and that you're able to underpin your advocacy claims with robust evidence that can be accepted by global health and international partners. There is a little bit of a need for those working in these sectors to be a little bit less defensive. So very often if something is published that says, so for example, there was a World Bank study that I was a part of, and what it did was it looked at the national household utilization data. So it asked people at a household level what service they utilized in the whole country, and it counted the utilization figures. And so, for example, those estimates were much lower than the estimates comparing numbers of hospital beds because the pie was bigger. It was looking at all, including chemical dealers and private providers and all kinds of other things. It was asking people, when do you go to a faith-based health provider? with an array of other options. And so, of course, because the pie is bigger, the percentage was lower. But there was a huge outcry where people felt that those percentages were somehow undermining the advocacy agenda and were somehow being put up against these estimates of hospital beds, for example. And it just simply was not the case. So there's a need for a slightly less defensive strategy, and certainly a more strategic strategy with regards to advocacy messaging. So I would suggest that an advocacy approach, which quite clearly focused on an evidence-based messaging about, for example, a reach to the poor, is critically important, and doesn't necessarily have to be a reach to the rural poor, which is an age-old message that has been hanging around in the different discourses without actually possibly even being necessary anymore, or being right or relevant anymore. Last slide. And then, of course, for the researchers, and it's the same messaging for the researchers and those supporting research and research translation, there's also a huge need to be more precise in how data is utilized. And I must stress that it's often researchers that have perpetuated these problematic claims by not being critical of the data that they've been utilizing and just sort of accepting because something else has been published that it is correct. So there's a need for a much more critical approach to evidence with regards to faith-based organizations, more sophisticated research that much more clearly draws on multiple dimensions. And I just put this picture on the side, which is just to give a reminder that something like universal health coverage is being measured amongst a number of complex measures and indicators. It's not an easy thing to do research on, but it is a really necessary and important thing to do research on. So we're needing more sophisticated evidence and research. I think there's a need for researchers to be more supportive of the faith-based health providers and the CHAs to understand the advocacy and policy engagements that they are involved in, and to help them provide the right evidence for the right engagement. I think there's a need for more responsive health research agendas and research that's more relevant to the global agendas and the local questions. And I think I'm going to stop there. The next slide, if you'll just go on to that one. Thank you. And if you can just pause on this slide, I'm going to hand over to my good friend and colleague, Mr. Peter Yeboah, who I'm sure will have some thoughts. I don't assume he's going to agree with everything I've said, so I'm going to leave it at that. Thank you very much.
Yes, right. Thank you very much, Jill. Thank you very much, panel, for this elaborate exposition of the fact that, I would like to start from your call, the call for faith-based providers to be precise with evidence, less defensive and more strategic with advocacy messaging and the rest. I think that I would definitely say yes to that. I will validate what you say, corroborate with you on that level. If there has been a time in our partnership, or relationship with, with government or other actors that require, that has become what I call 3Ds. Documentation, data-driven, and then dissemination. This is the time that we are experiencing it most. Anytime, anywhere, we are being asked to demonstrate, or for purpose of attribution or contribution to the health sector, or even to justify why we are at the policy table. Anytime we are asked to show evidence of our specific contribution in the health sector. So certainly the case that the call for evidence, is growing higher and higher, much more so in our quest also to be sustainable, purpose of sustainability, accessing funding, government funding, negotiating with government for resources and the rest. Definitely evidence is sought. Just 2 weeks ago, I sat at the policy table with the Minister of Health and the Director General of Ghana Health Service, and they were allocating doctors to all agents in the health sector. And my point was that, hey, institute the principle of equity in the allocation of human resources to the health sector. They say, Peter, why do you say so? I said, well, we provide 30% of health service, so give me 30% of the doctors. Of course, I would say with posturing and using some emotive arguments and the rest, they said yes to that. But certainly, I was asking myself, how do we really prove that indeed our claims, how do we provide evidence of our claims that we provide 30% or so? And even how do we also objectify by evidence some of our core values, which is of course very difficult to justify? Pro-poor, assisting the vulnerable, less privileged, respecting dignity, or we often call ourselves armies of compassion. That is fine. How do we justify so? I would just say that probably it is time for faith-based health providers to situate evidence itself in our scheme of things, which hasn't featured very well. How do we appreciate evidence? How do we conceptualize evidence? And how do we use it at all? And much more, how do we invest in evidence that are there? I would say that that is one area that faith-based health providers probably would need to have a second look at that. In our quest to engage in advocacy, partnerships, negotiations and lobbying, we don't have probably the leeway to be a bit, to be defensive or emotive. So it's about looking at how can we appropriately invest in evidence properly, and how do we also leverage our platforms, that convening power and moral authority that we have, to an effect. And even how do we also institute our, much more robust evaluative mechanisms? Having the infrastructure to accurately measure outcomes. How effective are we? How do we even generate new research on health programs, effectiveness, and the rest? These are questions that that we are being confronted with, and then also, despite our broad platform, we are always searching. How can we leverage our access to array of professionals, our access to populations, our access to all the safe public spaces we have, the church space, the hospital space, the school space, and the social space? How do we do so? It is about capacity. But I also think that there's the need for, for a new, for us to adopt that sort of research culture, which probably, I would say for CHAG, that over the past couple of, the past 2-3 years, we have been prompted to be actively engaged in research with another auspices of Prof. Jill, speaking now, and then with from Cape Town University, doing that, becoming very conscious that we can generate evidence, use evidence for advocacy, for negotiations, for partnership, and then to promote, our common mission. I think that there's a need for reorientation from all faith-based health providers, for it to go so. But much as we are also very much excited with evidence, I'm still struggling to question, understand, can we generate evidence on all our core values? Is it feasible? Is that not what makes us different from the others? Do we always need to quantify our contributions to the health sector, to health and healing? And if even so, if you're not able to use evidence or provide evidence of our core values, our distinctiveness, our compassion, our unique way of doing things, is there ways and means to demonstrate or probably to objectify our identities, our uniqueness in the health space? These are questions that we are being confronted, for which I think very necessary. And even how do we, invest in research itself, that documentation? The case of Ghana is one example where it was CHAG that pioneered and piloted 40 community-based health insurance schemes that were nationalized. We began, home-based care for HIV, AIDS, and the rest. But now to date, but for the fact that some of us will have institutional memory, you visit the policy table and they have no appreciation of CHAG with respect to the stats of, of the health insurance scheme. Recently, they celebrated their 15th anniversary. But for me, calling the CEO to say, hey, do you know the history of this? They have no idea. So the whole thing is about how do we reorient faith-based health providers with respect to generating evidence, investing in evidence, generating evidence, using evidence to promote our common mission of being effective in health outcomes, of living up to our mission. Probably these are the initial intervention that I'll make to Jill's brilliant submissions. But I think my question is still very much relevant. We believe in evidence, we need evidence, but then can we provide evidence on all aspects of our uniqueness on the health space? I think that is a question that we need to answer. But certainly, we cannot escape the fact that we're in an era where, for the purpose of attributions and the need to demonstrate our contributions, we are required at any point in time to provide data, to be data-driven, document and disseminate, hard evidence to our partners who probably much appreciate our uniqueness, our intrinsic values, and yet require hard evidence to do what we do. Over. Jill, over.
Thank you, Peter. That was great. I'm going to just take a few minutes. I'm going to ask the organizer just to open up the lines and just see if we have any burning questions from the attendees. There might not be, but let's just see if there's any burning questions for clarification, and just to give everyone a bit of a space to talk if they would like to. Sorry, I can't see from my side. John, can you just clarify that people are able to talk if they want to?
I think, Jill, they can ask questions through the question or chat function, and we have one question that's been submitted. I'll just read it out loud, and then those of us, Peter or you, can weigh in. The question is, the challenge from my understanding is how to promote evidence literacy. FBO facilities with low resource priority, who have low resources, it's a low priority, this question in regard to service provision. A conscious and deliberate effort is required to help them appreciate the generation of evidence, the process for gathering evidence, and to report on evidence. So under the question of how do we capacitate local faith-based health providers at the local level to be part of these practices for generating evidence and gathering evidence.
So I'll take a quick stab at it, and then Peter might want to jump in as well. And John, I think you're going to speak to capacity for research a little bit later as well. But I think this is not unique to local faith-based health providers. I think it's even to all types of health systems actors. The idea that people are very busy doing and don't have time for research is a very common issue, especially of course in research-constrained environments. My understanding is that there are multiple approaches to this. One approach is to sort of develop a specific strategy to try and build low-level research capacity within these institutions. And research doesn't have to be a 10-year randomized control trial. I mean, research can be a process of reflective practice that is added into the monthly management meetings of a facility, for example. So I think there are multiple approaches to where lighter touch and smaller scale research, let's say research with a small r, is built into the everyday practices of these institutions. I mean, I think that's certainly well within the grasp, but doesn't require any additional resources. I think the other approach, which is now being kind of globally being focused on, is things such as embedded research. It's the type of research partnerships that happen where research institutions partner with faith-based organizations, for example. And Peter alluded to it. I mean, we are partnering in an externally funded research project where the university and the Christian Health Associations are working together on a project. But there's also lots of embedded research approaches where, for example, things such as postgraduate students doing thesis work. There has been a lot of thesis work in relation to faith-based organizations. Yes, the management of those partnerships and relationships take time and energy and a lot of and some negotiation for sure to ensure that they are useful. But I think there are multiple approaches that are being utilized and are available. I think sometimes it's a case of sharing experiences and ensuring that on the ground, the people in the local faith-based health facilities have the the knowledge and the capacity to be able to manage research, to manage, in the sense of manage the research relationship, to understand where the boundaries are, to understand what is appropriate or not, to understand what is ethical behavior on the parts of the researcher or not. That type of knowledge is often really important, because otherwise there is the risk that of the research just not being useful. Peter, any thoughts on your side about how local kind of community level organizations, or let's say a hospital or a facility, can engage in research and evidence without it being too
Yes, very much so. I think beyond the capacity issues that you alluded to very well, I think it's about also providing incentives, incentivizing research in our local institution. And it's, I've been saying that there's also the need to demystify research as that extractive type of enterprise where most hospitals have been used to having a PhD student coming in or a consultant coming in, taking all the data, and then later inundating the hospitals with much more data without them seeing any direct benefit of it. I think if you can incentivize research to say, look, whatever research agenda that comes in, even the faith-based providers helping to shape the research agenda so that its relevance, right at the outset, becomes some part of a critical reflection, on performance, on the institution's performance for continuous quality improvement. I think it's about, I spoke of reorientation. If we can really provide incentives to faith-based providers and say, look, research is an integral part of it's part of your mission. After all, we are always looking at how can we promote holistic healthcare, try to use messaging, trying to say, look, that research is not an extractive enterprise, it's part of your core mission, and there are also specific benefits, to the patient, to the institution, sustainability, and other issues that are part of it. I think that will really help significantly in building that culture of research, incentivizing it, and letting it be part of that. And I think that will also definitely start with engagement of faith-based providers who we all understand are huge resource for the research that all of us are really talking about. So I will still emphasize on incentivizing, research and evidence as part of it. And sometimes the way the evidence itself is used for or against them. Some people have had situations where they say, well, this research established that this CHA is not really as relevant as it was. The way we also disseminate research findings to them might also play a role in incentivizing, the uptake of research or evidence in that matter. This is, my intervention briefly on that. Thank you.
John?
A lot of substantial response. We now have David Barstow has raised his hand. David, would you like to comment or add a question into this content area?
Yeah, thank you. Jill, with all of the problems that you have talked about the estimates and the ranges and things like that, is there still something useful that can be said? Like, could we say, well, generally 20 to 40%, or, something like that? Because it's really very unsatisfying to say we don't have enough evidence, so we can't say anything.
David, yes, we can. What I'm arguing is that we shouldn't be trying to say 40% of all healthcare in the world is provided by faith-based organizations. First of all, there's no way of making that judgment. And secondly, it's just too general to even be useful. I'm saying you can make claims, but they have to be really specific. So, for example, just referencing the work we've done in Ghana with Peter and Chag, we counted the very precise number of different types of facilities, and you can say this % of teaching facilities versus that % of teaching facilities, or you can say this % of Chag facilities are located in rural areas where there is no other public facility within a 100-kilometer radius. That kind of much more specific estimate is what you can provide. And that's what I was saying, that's what I was alluding to with those later references, where there is emerging reference which has that really specific evidence base. But unfortunately, the translation of that type of research, which can be quite technical, into the advocacy space hasn't really happened. And I think that's a function both for researchers and for practitioners, is to create that bridge or that translation of highly technical evidence into robust evidence-based advocacy that isn't so general and vague that it's actually meaningless. Does that make sense?
Yeah, I just wish there was something we could say now in a general way, but maybe there just isn't.
So again, what I'm saying is there is evidence that you can say now, but it'll be to a specific indicator in a specific context. It's not going to be to all FBOs, which first of all we don't even know what that means, to the world. And I think that desire, what you're feeling, that need for some kind of estimate is actually showing you how strong that discourse has become, because it's seen as a really important thing to have to say. And what I'm arguing is that perhaps it's not actually that important or impressive to be able to say it, and then rather saying something which is specific and evidence-based is probably going to be more powerful on advocacy, for advocacy.
Yeah, may I have a perspective, if I may? Can I make a contribution? Yeah, thank you very much. Last week we had a session with the National Health Insurance Scheme of all providers, and I was so struck to learn from the CEO of Ghana's National Health Insurance Scheme that child facilities constitute only 6% of all accredited providers of the National Health Insurance Scheme, and yet they provide 25% of the entire contributions. I was naturally excited. I mean, it was a huge efficiency index, 6%. I was excited and relieved because such a statement, hard evidence, was coming from the National Health Insurance, scheme, or National Health Insurance Authority, telling us that even though we constitute 6% of health infrastructure in terms of service providers, our contributions are much more higher than Ghana Health Service, that has about 60%, and yet they provide less. So when it's about people telling you about what you do, it's exciting. But if it's coming from us, because we don't have robust infrastructure to be assertive and the rest, it can be very much hurting when somebody is able to challenge that, hey, Peter, your statement that you provide 30% or 45% is not true. It affects the integrity, our credibility as faith-based health providers. So probably I will be much more, cautious in always leveraging or trying to take refuge in attribution. I will highlight my contributions. Sometimes other qualities, other value additions to the health sector that helps us very well, until we are very much sure that indeed our statements, the figures we churn out are true. It is certainly not pleasant at the policy table to be challenged that your figures are wrong. It is very much embarrassing, I always concede. So just to say, we can be exploring what are the other value adds we bring on board in the health sector that makes us unique, and for which I think that legitimizes our stand or our place on the policy table. I think that is very important at this stage, in addition to robust evidence. That's what I would say.
Thank you, Peter.
Thank you. Excuse me, we are monitoring time and participation, and Gabriel has his hand raised that he was the one that initiated this question. So we wanted to invite Gabriel into the mix, and then we'll shift to John's presentation after that. Thank you. Gabriel.
Okay, thank you so much. I just want to make an appeal to Peter Yeboah, given the fact that he has a key role to play in the African Christian Health platform. The important thing is the fact that most of our health facilities collect data from the routine service delivery they are offering. Right. But the issue is that they don't have the capacity, once, to be able to package most of those information and evidence together, process and share. That becomes what comes out from even that small locality where they are working. And it gives an idea about the health delivery and their efforts they are making vis-a-vis the community where they are serving. I agree that completely it is not every information or every services offered that can be provided by evidence. But the ones that they can provide evidence from, they should be able to be offer the kind of assistance that can help them to put it together and share. So I thought your platform, Peter, provides an opportunity for us to be able to emphasize this evidence literacy and the import of us having that capacity to be able to process this data and share. That's one. Two is the fact that it's very critical that faith-based institutions and facilities should start seeing clearly the need to be able to show the extent to which they are contributing to national efforts. And that has to come through by way of evidence. How many patients are being treated for HIV in healthcare facilities owned by faith-based institutions? It's easy to put those information together, and nobody will contradict those kind of information. So I think we need to start incrementally to show the contribution of faith-based health facilities to national effort by starting even just from the point of view of even disease specificity. That's just the point I needed to make. Thank you.
This was a fruitful exchange between Peter Yaboa, head of the African Christian Health Association platform, and our colleague from UNAIDS Nigeria. Thank you. It's time now to shift to a presentation and more content to be offered by Professor John Blevins.
Thank you, Mimi. I'll go through this quickly, keeping in mind our time. What I wanted to do in this presentation was to lift up some of the claims that are often made and have historically been made of the distinctive contributions of faith-based providers that Jill's already laid out for us so helpfully in the first part of the webinar this morning, and to talk about the challenge of making these claims in a context in which they might be challenged, and how faith-based organizations, religious leaders, faith-based health providers, and health networks can articulate a point of view to speak to the both and of the evidence, and not only to highlight the side of the contributions of the faith-based sector, but also speak to the questions of gaps in evidence or the ways in which there are limits to the contributions of faith-based providers, to be more transparent about the complexity of some of these issues. And so I organized this around two general areas: social capital and the question of motivation and longevity, the time in which faith-based organizations and religious communities are parts of communities, broader communities, and not just reliant on funding. So in regard to social capital, I want briefly to talk about the question of trust in norms and the question of capacity. In regard to motivation, to talk about the question of reach to the poor, the question of funding and funding streams, and what we know and don't know in regard to organizational culture. Next slide. So there are some qualitative studies that do indicate that faith-based providers do enjoy a greater level of trust when compared to providers from other sectors. One way that I like to think about the question of trust is from the point of view of social capital. And if we think of social capital from the point of view of relationships that play out in a social context, we can think about what generates, maintains, and strengthens trust is the quality of relationships in that social context that are perceived to be beneficial, either in material ways to individuals and communities, or in regard to providing a kind of framework of right and wrong from the point of view of religion. In regard to the material contributions of faith-based organizations, there is some there have been some qualitative studies that demonstrate that faith-based providers are generally perceived to be more trustworthy than are providers from other sectors. And you've got two citations here of some reports and research that have asked that question and provide some information on it. But the question that's going to often be raised in the context specifically of HIV is both a question of trust and also the question of the ways in which religion may actually be a driver of stigmatization that some people who are living with HIV or who are affected by HIV face. Particularly some communities that have high HIV disease burden, such as men who have sex with men, sex workers, people who inject or use drugs, what PEPFAR and UNAIDS and other global partners speak about as key populations. For those kinds of communities, the question of religion's function in regard to stigma is often a rejoinder to the claim of faith-based organizations and faith leaders speaking to the greater trust that religious communities enjoy in this regard, as a rejoinder to, well, yes, but for people in civil society and advocates in HIV settings, there will often be a sharp rejoinder to the question of trust being built on the same ways in which religion also increases stigma or can be used to increase stigma for some groups. And there's some research or claims in this regard that you see here, both in regard to research of religion's role, Helen Epstein's work in Uganda and Nigeria and other parts of sub-Saharan Africa, and a policy piece out of the Center for American Progress by Scott Everts, the first director of PEPFAR, on the ways in which religious ideology has impacted PEPFAR's activities in ways that have not been helpful to marginalized communities. And then some work that shows that prevention messages related to abstinence-only prevention actually don't have a function of encouraging prevention, but provide a framework for making a moral claim based in a certain kind of religious reading as to how societies should be structured. And so you've got these two kinds of, Jill talked about discourses. You've got these two kinds of discourses that end up talking past one another of the question of trust and the importance of trust that religious organizations and religious leaders enjoy, as well as this kind of criticism of religion as being a driver of stigma. And faith-based organizations get caught in the middle around those. What I would encourage faith-based organizations and leaders of faith-based health providers to think about is how to articulate not the either or of these questions, but the both and of this question, and to be able to demonstrate the ways in which they use the trust that is entrusted to them, that's generated for them, in helpful ways for the community at large, and also to articulate their commitments to serving people regardless of circumstances in which they come from, to be able to speak to these kinds of rejoinders. There's a way in which faith-based organizations can speak to the both and of these kinds of questions that are part of what drive this question of trust and norms. Next slide. In regard to capacity, Jill's already talked about what we can and can't say at this time in regard to capacity, but there is data that demonstrates that faith-based health providers are supplemented by services that local religious communities contribute at a local congregational level, and the ways in which congregations can mobilize volunteers for community initiatives, although there's also evidence that shows how difficult it can be to coordinate these efforts and to measure their effects. But if there's ways that we know there are limits as to what we can say in regard to capacity, then there are ways also in which broadening the question of what capacity looks like by faith-based health providers and faith-based organizations can speak to this question of capacity beyond the framework and the way it gets framed by the global funders alone, and can speak to the distinctive contributions in regard to capacity that are part of what faith-based organizations do that have nothing to do with numbers of beds or percentage of market share at a country level. Next slide. And then regarding to motivation and longevity, Jill spoke about there's an anecdotal claim that faith-based organizations reach to the poor, but there's actually, there is some data that shows that local congregations provide, a large number of local congregations provide material support to the poor But there's also some data, and Jill's and colleagues at the World Bank were generators of some of this data, that demonstrates that faith-based organizations don't necessarily serve the poor in greater numbers than do other providers. And so we've got mixed data on this question as well, and Jill's already alluded to the importance of answering this question in broad kinds of ways. But since most of us who are working in faith-based health facilities are not researchers, but are busy doing work, what can we say in the interim? Well, if you broaden this question about reach to the poor beyond elements of simply capacity to do so in regard to the broader question of whether faith-based health providers provide us a significant proportion of services or not, but speak to other kinds of contextual issues that vary from country to country and place to place, faith-based health providers and faith-based organizations can begin to say something about the reach to poor communities in their local context. We looked at some work that pediatric HIV programs in Kenya carried out as they began to work with growing numbers of adolescents who were living with HIV, and found that the question of whether they reached the poor in greater numbers wasn't answerable because they didn't have the capacity to address that research question. But what they were able to demonstrate by talking to participants that they worked with and to their families and broader community members in informal settlements where they worked is that faith-based organizations were essential providers for the urban poor around Nairobi, because they provided the only kind of organizational structure that was trusted and that had sufficient capacity to meet the needs of adolescents living with HIV and their affected family members. And that for the context in Nairobi, in Kenya specifically, that without the service provision of faith-based organizations in 8 informal settlements around the city, that adolescents living with HIV would have had far less access to services. And so it's not generalizable, but it is data that demonstrates that there are ways in which the distinctive capacities of faith-based organizations can reach into this question. Next slide. The financial support of HIV programs from faith-based organizations is substantial. One UNICEF report estimates that the combined funding of faith-based organizations to the global HIV fight is $5 billion, which is an amount that equals the combined funding of all multilateral donors. So there is some data that demonstrates the importance and the high level of funding, but shifts in funding can be very disruptive to faith-based health providers. And the questions of reliance on funding streams by global funders and global partners such as PEPFAR or the Global Fund becomes a key question in regard to these kinds of policy questions. So being able to articulate both the contributions and the challenges helps for faith-based health providers and organizations to articulate a fuller message in regard to funding. And then there's so much we don't know in regard to the capacity of faith-based organizations to carry out services at a structural level and what kinds of structures enable what kinds of services. We do know that the distinctive nature of faith-based organizations and the structures of ecclesial organizations allows for services at local, global, and international, local, national, and international levels. But there's a lot we don't know about the contributions and the organizational structure of some kinds of Christian organizations. In Kenya, fully 1/4 of the HIV services provided by the faith-based sector are provided by independent, mostly evangelical or Pentecostal Christian health facilities that are not part of the networked Christian Health Association platforms that we know about in the country, either Protestant or Roman Catholic. And so a significant proportion of what's provided by the Christian community in Kenya is being carried out through an organizational structure we really know very little to nothing about. And the organizational structure of non-Christian religious traditions, of Islam, of Hinduism, of Buddhism or Confucianism, and the ways in which that structure provides a framework for providing services is something we know very little about, and most of our work on the contributions of faith-based organizations has been on the contributions of Christian organizations. And we need very much to understand how the organizational structure of other religious traditions allows for distinctive services in their context in other parts of the world. And we really know next to nothing about that right now. So that's one of the questions in front of us. And so finally, next slide, key points. The survey I've mentioned to speaks to some policy analysis and qualitative study that demonstrates their capacities and contributions as well as limits. And from the point of view of advocacy, faith-based organizations are going to need to be able to articulate both sides of that message and to articulate where they stand on the complexity of the contributions of the effects of faith-based organizations and the effects of religion on service provision. And as Jill mentioned, there's an urgent need to move beyond anecdotes and general claims when speaking to funders, to policymakers, or to other providers, because we're now at the point where that question is met with a rejoinder of some sense of suspicion or skepticism and wanting too robust or optimistic claims to be backed up with evidence. So being able to speak to the complexity of this issue becomes more important, not just in terms of transparency, but being able to be seen as an advocate for services that speaks a message that actually speaks to the complexity of the issue. And then the importance from an advocacy perspective of combining message that highlight the evidence of FBO contributions in terms of what counts as evidence to different kinds of communities, what counts as evidence to PEPFAR, UNAIDS, the Global Fund, or National Ministries of Health will be different than what counts as evidence to a local congregation or to religious leaders. And so being able to provide a message and a framework and a discourse that speaks to those other audiences becomes an important kind of capacity for faith-based organizations and faith and religious leaders to be able to develop. So those are some key kinds of questions in regard to the broader issue of the debates today around what counts as evidence and how we can advocate for the distinctive contributions of faith-based providers.
So no further questions.
I think we're out of time.
Okay. All right. Thank you, John Blevins. Thank you, Peter Yaboa. Thank you, Jill Olivier, and thank you to all our participants. We're delighted to have spent this time with you. Thank you for your engagement and your attention, and hope that it was valuable for you. Gabriel, thank you for your language of research literacy, and we hope that we have perhaps made a contribution to that and in developing this as a resource for others. We invite you to join us for webinar number 4 on March 5th at the same time, also on a Tuesday. The focus of that webinar coming up will also be on generating evidence and distinctiveness, but with a focus on local faith communities. So bridging out from the faith-based health systems, healthcare, to local faith communities and faith-inspired community organizations. Please invite your colleagues and organization partners, others that you think might be interested and find this valuable. And remember again that the webinars are being recorded, so you can point people to this website as a resource for the previous webinars and this one, and anticipating the next one as well. Again, thank you, and we appreciate your time with us.